This is a brief guide on note keeping in ward, mainly applicable to antenatal or gynae ward, but it can be utilized in anywhere you work. So this is mainly intended for our trainee house officer students, but maybe a refresher for experienced doctors as well. Note keeping is the most important thing which we do in the ward, because if nothing is written on the notes, it has not happened. So to save yourself from trouble in medical legal scenarios, correct, clear note keeping is essential. So the basic principles are that you need to label your notes with date, time, where they have written. If you need to add anything later, always start a new note, notate the date and time. Don't go back to the chart and change any information. It gives a suspicion of hiding something, even if you don't want to do that. If anything is handwritten, make sure to write it legibly. And nothing is defensible if cannot be read. Always sign your name at the end of the note with your name in block letters. The general format for note writing is called SOAP. There is the subjective assessment, objective assessment, and then your assessment including clinical examination as well as investigations and your plan. The subjective impression is actually how the patient is feeling and what are the complaints and symptoms they are experiencing. Try and use as much as patient's wording here when you are writing. This is where you would record objectives. Is the area where you would record the vital signs, fetal heart rates, contraction information, as well as any lab data. The assessment is the assessment of the fetus and the maternal condition in few sentences. In pain, in labor, having show, is having early pregnancy bleeding, or past products. That is your assessment. Then your plan is a clear plan for each of the patient's conditions which are detected at the previous subjective and objective assessments, and the things which you have highlighted or identified for action. Triage is a part of the initial assessment or an assessment in any hospital or in ward. You are basically doing a mini history and examination, and your goal is to identify whether the woman and her baby are normal, and the second, whether the patient needs to be admitted immediately to the hospital or to the labor. So always you have 4 questions to ask: whether there's any vaginal bleeding, whether she is having contractions, if so, including the time of onset, frequency and intensity. And if she has been having lico leakage, time of that, as well as the color of the fluid and the quantity of loss. And whether the baby is moving, if not, how long since it has last moved. All these things are important. So we'll have a look at the sample SOAP admission history and plan. The subject, so you can write it somewhere similar to this. The patient is, say, the age at GP at weeks by LMP. LMP is sure, unsure, scan, whatever. Presented with the chief complaint of pains, rupture of membranes, bleeding, etc. He complains of contractions, reduced fetal movements, or whatever. The 4 questions are here. And her antenatal history is complicated, uncomplicated. Past medical history, past surgical history, obstetrics history, gynecological history, and any adverse reactions of the drugs, social history, family history, and any medical or medication history. That is your subjective assessment. Then your objective is fetal heart rate, pulse, BP of the mother, temperature, variability of the CTG, acceleration, decelerations, and categorization of the fetal heart rate trace and the contractions, torque activity. Then your general examination, head, eye, ENT, and ears, lungs, heart, abdominal and external genitalia, genitourinary, cervical dilatation, and estimated fetal weight after Leopold's maneuvers, as well as the presentation. And if there has been any ultrasound, whether the baby has been assessed with weight. Your objective parameters are antenatal blood tests, hematocrit, rubella, amniocentesis reports, hemoglobin analysis, full blood count, platelets. If the patient is Rh negative, whether anti-D had been given or antibodies had been assessed, ultrasound estimation and confirmation of dates, and POA or gestation calculated by corrected dates, and any estimation of fetal weight and other abnormalities of the ultrasounds. And then your final assessment is patient is, shall we say, 35 years old, gravida 2, para 1, at 35 weeks of pregnancy and 2 days of pregnancy with prenatal cause uncomplicated by gestation diabetes, having admitted in labor in active labor with signs and symptoms of premature arterial membranes. And your history findings are like this. That way you can continue. And then your plan, whether you need to admit, continue fetal monitoring, need consent for delivery or counseling for delivery, and pediatricians and anesthesia have to be informed, and if that's necessary, say if there's rupture of membranes, penicillin prophylaxis for UBAs, like that. So all the actions, giving magnesium sulfate, giving dexamethasone, preparing theatre, all that is your plan. So it's very simple, easy and straightforward. So it will be very useful for your THO job. That is what you need to practice. And happy THO job.